Welcome, everyone, to HCAHPS 2024 Improvement Trends You Need to Know. I am your host, Marcus Engel. Thank you for being with me today. Thank you for joining this webinar and for your interest in improving HCAHPS and thereby improving the experiences of the patients at the other end of the stethoscope. As I said, I'm your host, Marcus Engel. I have a Master's of Science in Narrative Medicine. I am a certified patient experience professional through the Barrel Patient Experience Institute, and I'm a certified speaking professional through the National Speakers Association. I am a keynote speaker, a healthcare consultant, an author, and a podcaster. And this is the second one of these webinars that I've done. About 6 months ago, we did another one on using narrative medicine to improve HCAHPS and patient satisfaction scores. And this time I thought I'd bring in a ringer. So instead of me this time, you're also going to get to hear from my good friend, Brian Lee. Brian, welcome. Thank you so much for being on with me today. I have no audio. I have no audio for Brian. Brian, are you muted?
So glad to join
there
you,
we
Mark.
are.
You and I have been hanging out for a long time together and collaborating and developing ideas together. So it's just an honor to be with you.
Well, I'm so glad to be with you. And Brian, as I guess I should introduce you, you were first introduced to me as a patient experience guru, and I have found that to be the case. But would you take a moment just to introduce yourself a little bit and also talk a little bit about custom learning systems and what you do?
Careful when you ask a speaker to talk about themselves. I've been doing this as of yesterday, 40 years. We're having a little party tomorrow to celebrate. Thank you. And we work with hospitals and clinic networks across the US and Canada to improve the patient experience. At the end of the day, we want to shift cultures to be kindness care driven as opposed to job driven, task driven, financially driven. We want to create and help our partners create a 5-star culture of healing kindness. And you do that by empowering the front line. If you want to be a provider of choice, you got to be an employer of choice. And so that's our work. That's our joy. That's really, at the end of the day, it's we help people who make a difference in the lives of people. We help make a difference in their lives.
Absolutely. And as you said, we've been knowing of each other and familiar with each other's work and collaborating on several different projects over the last, gosh, probably a decade.
Yeah.
And I'm such an admirer of your work. I know how beneficial it is to hospitals and healthcare systems. And I know how beneficial it's been to me just learning from you. I don't know of anyone that is more on top of what's going on in hospitals and healthcare systems and patient experience and employee engagement and retention. I don't know anybody who's got more knowledge than you. One of the things that I so look forward to every year is the Service Excellence Conference that you have in November. This year it's here in Orlando. And I want to encourage everyone to come to this conference. I'll be speaking at it. But every year at the beginning of that conference, Brian, you give kind of a state of the industry report. And I'd love to get some of your thoughts on what's going on in the world of healthcare today, specifically in the world of patient experience, but really in the overall ecosystem of what healthcare is. Can you give us kind of the synopsis of what's going on in the industry?
Well, we'll talk about the niche of healthcare where you and I live, and that is patient care delivery. So with hospitals and clinics and home health and all the related institutions. So the marketplace is struggling after having had the 3 years plus of the pandemic. The question that everybody's struggling with is now what? Without question, healthcare providers are psychologically burned out and tired. That's pretty consistent everywhere. Resilience is very popular subject with those working at the bedside. So psychologically, people still have not recovered. Number one. Number two, healthcare is struggling with staffing. And all the data tells us that one out of 5 healthcare workers quit over the last 3.5 years and left healthcare. And so while the challenge of staffing is not as bad as it was a year ago, the issue of staffing is not going to clear up for another decade. The marketplace is way behind in responding to new folks coming in particular nurses, but many other many other professions as well are struggling with staffing. So still we have about 8 or 9% of nurses are travel nurses throughout the industry. Thirdly, healthcare did very well under the CARES Act, the funding that came from the federal government in 2020, 21, 2022, but that money's gone. And so we're seeing a great deal difficulty with about 40% of hospitals with a negative margin, and rural hospitals in particular having great difficulty. So economics is a challenge, and inflation didn't help. Inflation has cooled in the last 6 months, but here's the problem. Your inflationary costs grow by 7, 8, 9, 10%, and your reimbursement grows by 2 or 3%, maybe 4. So there's a big gap there. So organizations are being very thrifty and very focused. Patient experience has been struggling a great deal. Numbers are down everywhere. If we look at the trending, there's no question when people are, there's a saying, the sight of the gallows sharpens the mind. And the other one is when you're up to your behind in alligators, you forget you're there to drain the swamp. But patient experience has suffered, and response rates to surveys have suffered. So because of all of that, CMS is introducing new rules January 1, 2025 to make some changes as well. So in a nutshell, healthcare is very much in a responding mode and still paying the price from the pandemic, and struggling to shift to the future of what it should be doing.
So a couple of questions before we get into what CMS is going to be requiring come 2025. You mentioned that you think that the staffing shortages and issues are going to be with us for the next decade.
Right.
I've been in this industry long enough, as have you. Staffing has been a problem since I can remember.
Yes.
What's going to be the major driving changes for that staffing to recover, I suppose, in the next decade?
Yeah. Well, every state has agencies that are paying attention to this, and some are providing interim funding. In rural America, there's SHIP grants that are helping with that. But agencies are attempting to get more nurses into nursing school, more CNAs into CNA school. I will tell you what's going to be a disaster for long-term care is CMS is bringing in new rules requiring a nurse to be on a nursing home 24/7. And I think only about 30% of nursing homes meet that requirement right now. Well, the problem is, where do you find these nurses? Where are they going to come from? So these new staffing regulations are drawing gigantic hostile response from the long-term care industry. So what we're seeing is kind of two forces. One is a variety of state agencies and national agencies are attempting to stimulate interest in through a variety of funding programs in more people coming into healthcare. That's trend number one. Trend number two, that's going to be a while. So if you are going to be successful in today's marketplace, you're going to need to get really great at two things. Number one, you're going to need to know how to hang on to new people when they come and reduce the average first-year turnover from 26 to 36%. You're going to need to reduce it down to less than 8%. Number one, you're going to have to get great at onboarding new hires. Number two, if you're going to succeed in all of this, you're going to stop counting on people applying for positions and go out and find the talent that you want. So two paradigm shifts. Paradigm shift number one is have a love affair with your new hires. Paradigm shift number two is recruit your own recruits.
Wow, that is a paradigm shift, isn't it?
Yeah.
Yeah, and I know that we talked a little bit there about long-term and skilled nursing facilities, but back in our world of hospital HCAHPS and such, what is coming down from CMS as far as hospitals are concerned in 2025?
Well, the new rules that are pending that are going to go into effect August 1, starting January 1. I'll just give you a quick little summary. They are predicated on the concept that CMS is concerned about the declining response rates. And so the big change that I think everybody needs to be aware of is that CMS is going to permit email surveys to take place effective January 1. And because they've seen response rates drop from 26 to 25 to 24 to 23% ballpark. I'm not, those aren't the exact numbers, but definitely that is and they're partly responding to I'm
Sorry.
not sure what happened there. They're partly responding to requests from the industry that the changes needed to take place. So that is one of the first rules that are taking place. Number one. Number two, they're going to allow family members to help the patient complete a survey. So a small change, but recognition that if they want response rates to stop dropping, they're going to have the patient's personal caregiver help with it. Number three, this is minor. They're going to change the collection survey time from 42 to 49 days. So when the cutoff takes place, they're going to limit the number of supplementary questions that can be asked up to 12. So, on a 29 question survey, you'll be able to ask up to 12. I got to say, just as an editorial comment here, everybody should be adding in the pain questions back, in my opinion, to the supplemental questions. So just a little strong bias there. They're now saying that you're going to have to ask the patient what language they speak. At the moment, HCAHPS surveys are bilingual with Spanish speaking as well. So there's some other small items, but those are significant changes. And the giant one is being able to allow patients to complete a survey online.
First of all, I like our partnership a lot because you're the nuts and bolts and the metrics and the numbers guy, and I'm the guy who brings it in to say, look, this is really going to help the patients, right?
Right.
If you can do an email survey as opposed to a hard copy survey, that at least it makes it accessible for patients like me who have a print disability. So this is opening up. Hopefully, we're going to see some of those things. I also very much love this idea that a caregiver is allowed to help the patient with the patient experience survey, because let's just face it, the last time I was hospitalized, which was a year ago, thanks to a water moccasin bite and spent 6 days in the hospital, I was on a lot of narcotics during that time, and my family members that were there were really a lot more attentive to the types of things that are on a patient experience survey as opposed to what I would have been laid up and on narcotics. So
Amen.
I think that's a really good move by CMS.
Yes, absolutely.
What about the
100%.
domains? Do they change at all?
No, but I want to comment here as well. HCAHPS, when it was developed in partnership with 7 survey vendors. And in my opinion, the survey vendors were attempting to protect their long-term financial viability and limited the number of questions that could be asked. Yelp did a study that showed that there were 11 domains that weren't being asked that were important to the patient. For example, cost. For example, no one was asking about acute care. Nobody was asking about reception and volunteers. No one is asking about dietary. No one is asking about a number of these areas which are important to patients. So there's a number of areas that are missing. The intention was that the survey vendors would then charge for a supplemental survey, because what's happened is these HCAHPS question survey have become commodity. Really, there's no difference and the way that they're asked and what vendor they asked, other than is it going to be paper, soon to be email, phone, what's the mode? That's the only thing that's different. So they left out a whole lot of other questions. And one of the reasons your listeners are struggling improving overall and willingness to recommend is they're not addressing those issues that are not asked. That's the challenge. Now, traditionally, we've looked at the 4 driving factors, the 4 significant areas that influence the patient. Number 1 is nurse communication and physician communication. Surprise, surprise. I mean, people value, the nurse has tremendous influence, nurse and CNAs. And then, of course, physicians, although their impact in some respects gets more weighting than it deserves because there's not a whole lot of physician contact in a hospital. Staff responsiveness is a big driving factor, but it's misunderstood. Because staff responsiveness, the question is help to the bathroom and response to call light. But when patients think of responsiveness, they think of everybody. And most of your listening organizations do not engage non-caregivers at the bedside in their improvement process. And that's a mistake. So that third area is staff responsiveness. And the fourth area is pain. And I want to comment about pain for a moment, Mark.
Yeah, please.
So because of the opioid epidemic, CMS responded and said, we got to change the pain question. So they did, because they didn't want to think that by asking questions, you're contributing to it. So they changed it to some innocuous questions, but still useful. And then they said, forget it. You don't have to ask questions about pain. In fact, we don't want you asking the questions about pain. And I believe that was a mistake. So I very much encourage all of our partners to continue to ask, because of course pain is a driver. You know, I'm a male. I have no idea how women handle childbirth. I don't want to even discuss it. I don't want to be in pain. I'm a weenie when it comes to those things. And how the hospital manages my pain and manages my expectation about pain is a big deal. I don't want to be experience it. So those are the 4 traditional driving forces that affect overall.
Other than those driving forces, I want to go back to, and driving forces, we talk about the staff that I want to go back to the responsiveness question that you said that most hospitals are not engaging their non-clinical staff, correct? And we're talking about environmental services, dietary, et cetera, to be involved in the patient's experience, right? How do we get them on board too?
Get them in the classroom. First of all, embrace the principle that everyone is a caregiver. Let's start off with that. You're at the bedside or support someone who's at the bedside. You're a caregiver. Because in hospitals, everybody depends on somebody for something, and we're all hopelessly codependent on IT. And what do? You call them up, one of 3 things. Did you turn it on and off? Have you submitted a ticket? And then they'll get into their I can do that pretty well anybody. But listen, IT plays a critical role. And I was at RML, which is an LTech in Chicago. And the chief vice president of information systems said, I tell my network analysts, don't introduce yourself as a computer guy. Introduce yourself as a lifesaver. Everybody needs somebody. And when you think about it, it takes a village to discharge a patient. There's 9 disciplines that are involved in discharge process. Everything is cross-functional. So we need everybody to see themselves as a caregiver. And, when I recommend that maintenance or dietary or billing attend our HCAHPS webinars, they would say, well, why should I? And I say, well, why wouldn't you want to know how you can support people to be more successful and effective at improving the patient experience? Why wouldn't you want to know? Think about this, Marcus. You know this better than anybody. Who has more disposable time with the patient, the nurse or the housekeeper?
Good question. Right. Yeah. We'd like to think that nurses have the most time with patients, but we know that oftentimes that's not the case.
We know it's often not the case. We would like them to have it. So staffing ratios matter. Staffing ratios are everything.
When we were first talking about this too, I asked you to bring a piece of evidence or two toward the table of some research studies that you've seen lately, maybe that are surprising or exciting to you. And I know that you had one that you wanted to share.
Yeah, I'm going to, I want to make reference to a study that was done by, it's called Evidence-Based Performance Indicators of Positive Inpatient Experiences by, it was done at the University of New Orleans, Elvira Kemp, Julie Trivet, and Cassandra Davis. And so they did a fairly extensive study in the past year. They had, and they looked at 4 consecutive quarters of patient surveys. And I gotta say, they took into account social determinants of health. But here's what they came up with, which I thought was rather surprising. They said the study shows that hospital quietness, nurse communication, and care transition positively affected patient experience. Well, let me just comment about those for a moment. Well, nurse communication, we've always known that that was a factor. Care transitions are one of the lowest scoring domains in HCAHPS. And what's the difference between discharge and care transitions? Well, discharge is about getting you out of the hospital safely and in a timely way. Care transition may be about moving you from one unit to another. It might be moving you from acute care to long-term care or another facility. So care transition is a little bit more complicated. And quietness. How can you heal if you can't rest? I'm going to comment about quietness. It's not so much quietness at night, but think about it. Everything about a hospital is noisy. You got equipment running, you have people moving, doors opening and closing, hallways that may or may not have carpet, yada, yada, yada. Hospitals are noisy places. So quietness matters, and I'll tell you where it really matters. I believe it's even more important to have a quiet healing environment in afternoons when patients are trying to nap and early evenings when patients are trying to nap, as it is at night. So hospital quietness, nurse communication, care transition positively impact patient experience, likelihood to recommend. Interesting.
Yeah.
But they went on to say cleanliness had little impact on recommending the hospital, which is surprising. That staff responsiveness had a minor impact on patient experience ratings, on likely to recommend, not overall, but likelihood to recommend. So I thought they're kind of interesting. I'm not sure I accept some of those recommendations, but I wanted to share it with you.
Certainly.
Yeah. So maybe you want to unpack that a bit and just talk about that for a moment.
Well, you're exactly right, because anybody who's ever been in a hospital for more than a day or two knows that a hospital is not a place to get good rest. There are constant interruptions.
Yeah.
And and of course, those interruptions have to happen for an acute care patient. But I really think you're kind of onto something there by saying the quiet in the afternoon and evenings is just as important as the quiet at night. We all need a restful, peaceful environment to heal in. And unfortunately, just due to the nature of things, the hospital is not always that environment. But if we can be sensitive to that, maybe we can help some of those patient satisfaction scores go up too.
Well, you think about it, about a third of our audiences are sleep deprived to begin with. No, people just don't get enough sleep. There's a great book called Outlive by Dr. Addy. I want to recommend it. There's a fantastic chapter on the significance of sleep. So to begin with, we're not starting off in a very good place, and then you're in a hospital and you got to heal, and you can't heal without rest. So one of the things we do is we teach the concept of a license to please. It's a very simple idea that we're empowering every caregiver to own the relationship with the patient. And there's 7 key skills. One of them is simply license to silence. License to silence means this: we need to empower every caregiver to speak with a quieter, gentler voice in patient care areas, and lower the lights during nap time in the hallways as a reminder, and fix aging things, fix things that go bang and clang. Duct tape goes a long way in a lot of things, and stop scheduling therapy sessions in late afternoons when people want to rest. Now, we cover all of those things in our HCAHPS Breakthrough Leadership webinar series. We have one webinar, and I know you know this, Marcus, we have one webinar in every domain, on every subject. And we break down the 11 key skill sets that are needed for quiet. But to start off with is if you're going to do nothing else and focus on quiet, give everybody a license to silence. Get everybody on board on this subject, that in those areas where we have patient care areas, they're going to be calm, quiet environment, and manage patient expectations about quiet while we're at it.
Managing expectations is always always a good thing, right? Always a good thing. And Brian, you and I decided before we got on this call today that we wanted to also make sure that those who are attending today walked away with some free gifts. So let me share my gift with everyone, and then you can share yours. Is that okay?
Let's go.
Yeah. So like we said earlier, that Brian has the nuts and bolts and the metrics and the numbers for all of these things. What I bring to the table is the heart and compassion and the simple reminder about simple human presence. So I would like to encourage everyone, if you would like more of that, or if you would like some help tying these very weighty patient experience numbers and metrics and domains and such like that. If you'd like to tie it all together with some heart, I want to encourage you to click on that QR code there that will share with you a short video called Compassion is Action. This is a video that I put together specifically for healthcare professionals that shares some of the definitions that I have come across of compassion, some of those that I teach at University of Notre Dame, where I teach pre-meds, the art of being with. And I hope that you'll go to that. And that is my free gift to everyone who is attending today. Brian, what is your free gift for the listening audience?
I want yours. So, so mine is the HCAHPS Breakthrough Leadership webinar series. Let me talk about that for a moment. It's 13 webinars, between 45 and 55 minutes per webinar. So the concept is to watch one a month for 13 months. And the bonus, by the way, is Marcus Engel. It's an interview with Marcus. So it's a webinar series. And each webinar has a downloadable learning guide of somewhere between 15 and 20 pages that has every conceivable aspect of what's in that webinar there. And it has an executive summary of recommended action steps. So along with that webinar series, and we'll give you access to it for 26 months, along with that webinar series, we have a program called Webinar Master, and it's a structured methodology of how to use the tool. So just very quickly to say this, Marcus, don't think you're going to change anything because one person watches it and tells everybody else, because that doesn't work. What does work is having everybody watch it together. So make it a lunch and learn. Ask the CEO and CNO to commit to watching every one of them. Feed them and they will come. Of course, the more carbs, the higher the attendance. And at the end, there's a test, 100-question test, and we will issue a certification, certified HCAHPS practicing professional. So that's our gift.
And that's a big gift. That's a big gift. I've gone through the webinar series. I've learned a lot. And even for someone like me who is not consistently working in the hospital as an employee, I go in a lot of times to speak and to consult. But even for somebody who is on the outside, I learned a lot. I learned a lot of things that can be applied not just in healthcare, but across life, because this is while we're very focused on healthcare, this is also just kindness. This is human decency. This is treating others the way that we would want to be treated. Along with that, you're also going to learn how to improve those very important scales of patient satisfaction. And I feel like we should also say that oftentimes clinicians might get a little resistant to HCAHPS, and I understand that. It's another regulation, it's another piece of bureaucracy that we have to go through. And I just want to remind everyone, though, that patient experience and patient satisfaction, it's a good thing. It's not there to be a thorn in your side. It's there to ultimately give patients like me some voice in their care.
Mhm.
And by keeping patient experience as part of CMS and by still asking these questions, it helps patients like me realize that we are not voiceless in our own care. We
Mhm.
have
Mhm.
some power. We have some say. So thank you for that free gift for everyone. And Brian, before we go into Q&A, I also want to give everyone your contact information. I believe that might be up on the screen there because obviously people are going to have questions for you. And you say reaching out by phone is the best way to get you?
It's easy, for sure. Email, there's my cell. Always happy to hear from folks and love talking about the subject.
Yeah, yeah,
Um,
this is something we're both passionate about.
yeah, this is our life. This is what it's
Yeah.
about. Yeah.
So we've got a little bit of time here today. If anybody has any questions, we are more than happy to answer those. You can put those into either the chat or the question and answer box there, and we will be happy to take any kind of questions. And in the meantime, I want to encourage you again to download the Compassion is Action video, watch it for yourself, share it with your colleagues, and then also get a hold of the HCAHPS Breakthrough Webinar Series too from Brian. That's going to be a valuable tool in your toolbox for working with your staff to try to get them to really buy into the importance of patient experience and patient satisfaction. So, do you have any questions popping up?
Well, I'm wondering, Marcus,
It sounds like they're not going away. So what are you excited about with the upcoming changes in HCAHPS?
Okay, so one of the questions that we got is that HCAHPS are not going away anytime soon. So what are the exciting things that we're uh, about the new regulations? And I said mine already, that being able to give patients more access to surveys, that's something I'm very excited about. How about you, Brian?
Same here.
Yeah.
The big excuse providers, caregivers use for not improving HCAHPS is the low response rate. And then they will say, and I've heard this many times, and then they will say, well, one bad one can ruin our score. And my answer is, well, why would you be okay with one bad one? Why would you be okay with one or two-star rating? Why should that even, would you even think about that? There's a way of eliminating all of that negativity if you'll focus on improving the patient experience. So anything to do to improve the response rate, I think is good. We have a tool called How to Improve Response Rates, and it's 7 ways that you can proactively get your patient experience, uh, patients to respond at a higher rate. So there's many things you can do. But by the way, don't think because your response rates goes up that your scores will improve. Now, that's the other mythology, that it's only a negative complaint. It isn't just a negative complaint. The studies, Shep Hyken did one in 2022 that said most Americans provide more positive feedback than negative, more positive reviews than negative.
And that's almost counterintuitive from what we used to hear. It used to be the stat was that if you had a negative experience at a business or a company, you might tell 11 people. But if you had a positive experience, you might only tell one or two. And so I think that part of our natural inclination to look towards the negative um, may not always play out in these patient experience surveys from what you're saying.
I don't think that cliche about, people will likely tell negative. I don't think that's changed. I think people do it. But in terms of willingness to actually go online or complete a survey, I don't believe the data doesn't show that it reflects that. My experiences based on the data is people tend to comment about extraordinary experiences. And if the extraordinary experience is positive, they love commenting. If you look at healthgrades.com, the average physician rating is a 4.4. So it's not out of 5.0. So it's not just negative. We're commenting there.
Right. It's not just negative. Wow. Well, Brian, this has been great. I've learned a lot. Thank you for sharing this with the audience. And again, we have the Compassion is Action video that you can go and get for free just for attending today. And then Brian also has the HCAHPS Breakthrough Webinar series that's coming up that you can get as well.
We have another great
We
question.
do have another question.
Deb asks, the proposed new HCAHPS dimension for CMS is care coordination and ask questions pertaining to teamwork and working well together. What are your thoughts on how we can do this best and impact the experience through this lens of teamwork visibility?
Did you get that, Brian?
Yeah, that's a great question. So some of the vendors have carried questions like that before. I think this is a valuable question because patients, every move you make, every step you take, every breath you take, every bond you break, they're watching you. I'm thinking about writing a rock and roll song.
Yeah,
I
was going to say that sounds like a hit.
Yeah, maybe we should go to Sting.
Yeah.
So here's the deal: they're watching. They got nothing else to do. So they want to know that you get along. They want to know that you talk to each other. They want to know that you collaborate. So, and insurers are incentivizing caregivers to collaborate with care coordination. That's what they want. They want the patient to be treated proactively and having to do self-care instead of paying a price with expensive treatment later on. So number one is manage up. Every time you hand off between one caregiver to another with the patient, say something nice about the other caregiver. Manage up, not manage down. You know who we've got to get on board with that? We've got to get physicians on board, nurse practitioners. So when the nurse comes in the room, they got to acknowledge the nurse in a supportive, positive, complimentary way. Managing up each other is builds confidence in the patient. It increases collaboration. It's a win-win-win. There's no downside for it. Number one. Number two, bedside report. Care coordination, outgoing nurse briefs the incoming nurse in front of the patient, engaging the patient, informing the patient, answering the patient's questions. Because patients always think they should save up questions for physicians who they never see. So bedside report as opposed to sort of bedside report is everything. Patient engagement, that's nothing about me without me. That's the second thing I'd like to suggest. Third is that it's vital that the unit set goals together for patient experience scores. Because when you start setting goals together, then you start reviewing your scores together. And I will say this, absolute must is that every unit staff meeting is read the verbatim comments out loud in the tone of voice that they were intended. So when there's a positive, supportive, appreciative comment, you want to have a tone of voice that says, I love you, man. And when it's a nasty comment, there needs to be some anger in that voice because this is a reality check. Now, if you use a phone survey, the beauty of it is you get to listen to what the patient said. You get a recording of their verbatim comment. So those would be three things I would start off with. And the other thing is we recommend, for example, for transition of care, that while you're hardwiring a better process, put a transition team together. Actually, meet and talk about these things and set some goals and have a process. Well, care coordination is the same thing. Get a team together while you're ironing these things out and and work on those things deliberately and consciously about what behaviors you want everybody to change. We do a little educational program called How to Gain a Buy-in from Anybody for Anything. And, I don't think healthcare leaders are ever taught, how do you get your staff to buy in? So I think this is a critical skill. I hope that's helpful, Marcus.
I think that's very helpful. So thank you. Thank you so much for that. And
Yeah.
Brian, we're running a little late on time here today, but I wanted to thank you so much for spending this time with me and with the audience, sharing your valuable insights.
My pleasure, Marcus. I could do this with you all day.
I know. We'll do it again sometime. How's that sound?
Let's
all
do
right.
That.
And thank you all again for tuning in this afternoon. Please reach out to myself or to Brian if there's anything that we can do for you as individuals or as a collaboration too. We'd love to help. So thank you all so much. Thank you, Brian.